A very good evening to everybody.
It's a pleasure to have you on board, Anuja ma'am and Dr. Bijoya. And I think Dr. Shriram would be joining.
Yeah. Hi everyone.
Good evening, ma'am.
Good evening.
Good evening, ma'am.
Good evening, Bijoya.
So, it is a very interesting topic that we are here to discuss today. The topic is irritable bowel syndrome. And irritable bowel syndrome is actually a complex problem, and it is a very common problem. Approximately 7 to 15% of general population worldwide has irritable bowel syndrome. As a doctor, I see these patients in clinic, and many a times we just tell them, "Do you have stress?" And you should manage your stress. And many a times we miss on very important points that could have helped patients. And nutrition is one part wherein I feel that as a doctor and as a otherwise also as a healthcare professional, that nutrition management in irritable bowel syndrome is of one of the foremost things that can we should do as a clinician or a healthcare professional, which would be able to help our patients for the long term and would be able to give them a very good quality of life. And today we have a very esteemed panelist for to discuss this topic. We have just let me share their profile. Just give me a second. We have Dr. Bijoya. We have Anuja ma'am. Everybody knows Anuja ma'am. She is one of the foremost leading teachers in education. And we have Dr. Shri Agarwal. I'll just open the profile slide and share their profile in detail. A lot of us today's webinar who have joined as an attendee are from the field of nutrition, and anybody who's there in the field of nutrition knows Miss Anuja Agarwala. She's a very avid academician. Ma'am has been a senior nutritionist and dietitian in the Department of Pediatrics, All India Institute of Medical Sciences, AIIMS. She has been also been working in the field of inborn errors of metabolism and has been supporting the Department of Genetics, AIIMS, and helping the children with inborn errors of metabolism manage their diet. And she's a honorable senior advisor for Inclan, and she's also a faculty in the Next Initiative and associated with the Ministry of Tribal Affairs. Ma'am is also a member of ICMR Consortium of Rare Diseases, and she has so many laurels to her credit, and she has written like loads of publications, and she is also one of the policy makers for nutritional guidelines in India. She is the National Vice President, Indian Dietetic Association.
Thank you.
Ji ma'am, a very warm welcome to you, ma'am.
Thank you so much, Shri.
Dr. Shriram Agarwal is a senior gastroenterologist who's working in Delhi for last 25 years. And Sir has done his MBBS from SN Medical College, Jodhpur. He's MD in medicine from AIIMS, Delhi, and he has done his GM training from GB Pant Hospital. After that, Sir has done his research, has worked as research associate in GB Pant Hospital, and since then he has been working in Mata Chanan Devi Hospital in Delhi. He is also a member of American College of Gastroenterology, and he has many publications, both national and international, and he has special interest in liver diseases or non-alcoholic fatty liver disease. We have academician Dr. Bijoya Bhattacharjee. She is assistant professor and program coordinator for Department of Dietetics and Applied Nutrition, MIT University, Kolkata. And she's also the founder consultant dietitian for RB Diet Clinic. She's founder of RB Wellness and Nutritional Academy. She has 21 years of experience. She's awarded UGC NET and she's pursuing her PhD. She has done MSc in Community Nutrition and Dietetic Management, and she has been awarded certified. She's a certified diabetes diet educator, and she's awarded FODMAP dietitian for RBS treatment by Monash University, Australia. She has a number of awards and accolades she has received, and she has been also the best nutritional faculty at PLCC and she has featured in various medias, magazines, and TV channels. I welcome you, Dr. Bijoya. I think Sir has also joined.
Yeah, he's joined.
Sir, please start your video so that I can introduce you.
My video is on. Can you hear?
Yes, we can see
He's
you.
on.
A very warm welcome to you, sir. Good evening.
Good evening to all.
So I think today we are here to discuss what is irritable bowel syndrome, what are the symptoms, what is the pathophysiology, and what are the things that we can do to manage our patients, both pharmacologically and non-pharmacologically. So I think we have already made a slide. Let me start with the slide. I think it's visible.
Yeah.
Yeah.
So I think Anuja ma'am, you may start with the general introduction. If what do you feel like irritable bowel syndrome? Like what is the clinical, what is this clinical syndrome that we are talking about?
Yeah. So basically, we're talking about something, irritable bowel syndrome, as the name signifies, that it is an irritation in the bowel, right? And it is actually affecting your bowel, it is affecting your gut integrity, gut motility. So, as a result of which, there is a lot of bloating, there could be diarrhea, there could be constipation, there could be so many different kind of manifestations, related to gut. And there's so many different kind of food. It could happen because of food, but there are so many different individual differences, but not one, as we say, one diet doesn't fit all. So it could be one food, then the other food, and the situation is so complex. I think I'll leave the pathophysiology and everything for Sir to discuss. But then, as a nutritionist, I can say that the diet is very complex in itself. And then exclusion diets, elimination diets, and then inclusion, starting an inclusion for a patient is very, very complex. So, and there is a connection between gut and brain, which Bijoya is going to. So I don't want to just step into everyone's this thing, but it is a gut related problem, which is irritable gut, which is inflammation, which is affecting the gut integrity, motility, and that's why the person can have a chronic kind of a problem which goes on, and to subside this problem, there is a complex kind of management which one has to follow. Usually, it is dietary management, which as a first line of treatment, management is a dietary management.
Right.
Mm.
I think I would ask Dr. Shriram if he would like to, tell us how it happens and why it happens, and how the gut microbials are affected, and like what is the syndrome in totality as a clinician. How do the patients come to him in the clinic? How do they present with?
So, irritable bowel syndrome, as we know, is a functional GI disorder,
Ji,
which nowadays are named as disorders of gut-brain interaction.
ji sir.
So, patients usually presents with a symptom of abdominal pain or abdominal discomfort as the predominant symptom. The characteristic about the abdominal discomfort or pain is that it should be related with the process of defecation or
Ji,
is associated with a change either in bowel frequency or in stool consistency. The
ji,
symptoms should be actively present in last 3 months, and the onset of symptoms should be at least more than 6 months, so that we can rule out various organic illnesses in this duration. And if the patient is present with these symptoms, we can consider that patients might possibly have irritable bowel syndrome.
ji, ji.
Next step is that we should look for anything which points towards organic disease. So that is what we call as alarm symptoms. So if patient complains of any alarm symptoms, which could be weight loss, loss of appetite, anemia, any bleeding with the stools, unexplained lump in the abdomen, then in these patients, we should investigate so as to rule out any organic disease being responsible for the symptoms.
Yes.
If patient has symptoms as I described, and there are no alarm symptoms, then we can make a positive diagnosis of irritable bowel syndrome. So there has been a change nowadays. Previously, we used to call it as a disorder of or diagnosis of exclusion, that you exclude all the organic illness, then you can diagnose a patient as IBS. But now there is a paradigm shift that we should make a positive diagnosis without doing much of the investigations if patient fulfills these criteria for diagnosis and there are no alarm symptoms. And minimum number of investigations are required.
Ji, ji.
Further, we divide these patients into constipation predominant or diarrhea predominant. The reason for classification is that the type of nutritional management and even pharmacological management is different in these individuals.
Ji.
So we have talked about what the irritable bowel syndrome is. We can go on to the next slide. So these are the Rome 4 criteria. As we know that all the functional disorders we diagnose on the basis of symptoms only. So there are diagnostic criteria how to go about it. So it is recurrent abdominal pain occurring on an average at least a day per week in the past 3 months. And the pain should be associated with the process of defecation or associated with a change in stool form or associated with a change in the stool frequency. Next slide. So alarm features we have talked. If the onset of symptoms is beyond 50 years of age, the duration of symptoms is short. There is weight loss or patient has nocturnal symptoms. There is a family history of colon cancer, anemia, or any history of rectal bleeding, then we must investigate these patients rather than labeling them as irritable bowel syndrome. Next, please. So this is the simple algorithm. If any patient comes to us with the symptoms, we ask them whether these symptoms fit into the Rome 4 criteria, that do you experience pain? Does this pain improve or worsen with the bowel movement? Or is it associated with any change in the stool frequency or texture? If his answer is yes, then we should rule out the alarm symptoms. If there are no alarm symptoms, we can make a positive diagnosis of irritable bowel syndrome. The importance of making positive diagnosis is that it reassures the patient. It gives it the confidence that there is no doubt of any serious illness in the doctor's mind, and he is not asking me to do much investigations. Next, please. So further, this IBS is classified into constipation predominant and diarrhea predominant, which has the bearing on nutritional as well as pharmacotherapy. And this is classified as per the stool consistency, not the number of bowel movements, but as per the consistency of stool as reported by the patient. So as per this Bristol stool chart, we have 7 forms of stool consistency from type 1 to type 7. So in this type 1, 2, and 3, they are considered as hard stools. Or if patient says that I passed stool from type 1 to type 3, this is constipation predominant. In the Western literature, type 1 and 2 is considered as constipation predominant, but in the Indian and Asian population, even type 3 is considered as constipation predominant IBS. And if patient tells that his stool consistency is from type 5 to type 7, then it is a diarrhea predominant IBS. Only type 4 is considered as a normal consistency of the stool. Next. As far as pathogenesis, the cause really is unknown, but there are multiple pathophysiological mechanisms which have been proposed to be responsible for the symptomatology. Important factors which have been considered are alteration in the GI motility, visceral hypersensitivity, impaired perception and processing of information by the brain, low-grade inflammatory activity in the GI system, immune activation, altered intestinal permeability, and gut microbiota alteration. And in different individuals, it is different pathophysiological mechanism which is predominantly responsible for the pathogenesis of symptoms. Next slide, please. And as far as management is concerned, the management strategy includes making a positive diagnosis, which is very important, establishing a good rapport with the patient. We must take into consideration the patient's perspective. Some patients might be very worried about a hidden organic illness. There might be some family history of colon cancer. So we must take into account the patient's perspective, and that must be addressed. Developing a good doctor-patient relationship is crucial to the management of IBS. And then we must pay attention to identifying contributory factors, which may be dietary, which may be stress-related, and address them. Next slide, please. So primarily in the management of IBS, there are three important steps. One is patient counseling, which is the mainstay of treatment. And then second important is dietary treatment, which is the focus of discussion today. And then comes the pharmacological management. So now I think I would hand over to you for the dietary treatment discussion.
Thank you so much, sir, for helping us understand what are the symptoms, what are the diagnostic criteria, where we should suspect IBS and where we should look for the red flags. And basically, would you be able to tell us like a little bit about pharmacotherapy? Which are the right candidates who need pharmacotherapy and which probably would not benefit only from nutritional management?
See, it is stepwise. As I told, first is patient counseling, explaining him the disease process. Second comes our simple lifestyle choices, simple dietary modifications. And then, yes, pharmacotherapy is an important role in almost in every patient, because addressing the patient's symptom is again very important, because patient's objective is relief of his symptoms. And that we have to provide, then only we can gain his confidence and treat them. So pharmacotherapy also, almost all the patients. Now, it depends as to which kind of pharmacotherapy. If it's a pain-predominant IBS, then we rely on antispasmodics or tricyclic antidepressants.
Right.
If it's a constipation-predominant IBS, then it is bulk laxatives and fiber supplementation, those kinds. And if it is diarrhea predominant, then we have different kind of drugs. So that's why it is important to subclassify the patient as to what is the predominant symptom, and based on that, we decide about the pharmacotherapy.
Right, sir. So, the next question would be for Anuja, ma'am. Ma'am, what are the different diets that we can suggest to a patient? And this I ask both as a clinician, and also this question is very relevant for the nutritionists who are planning for diet, who are planning a diet plan for IBS patients. What should they keep in mind, and what should they look for?
So first of all, I would like to say no fat diet works here, right? So we should not try on a lot of fat diets, but there are different kind of diets which may work, as they are, the manifestation, as we say, there are three different kinds of, this IBS. One could have constipation, one could have diarrhea, one could have both. So sometimes healthy eating modifications itself can work. This is the simplest kind of a thing, and we all know that alcohol and caffeine, we usually say stop all these things which could be irritants. Then reduction of fat in the diet, avoidance of spicy foods. Initially, when IBS, we started treating IBS, now a lot of people have done Monash, dietitians have done Monash courses, and we are very updated, and people are on their apps and they're finding out new things and all that. So we have implemented in the hospitals, but initially it was this kind of a diet, healthy eating habits, an increase of fluid intake. And we all know we used to manage like this. But this is of actually a little benefit to IBS patient, because this is quite a chronic condition. So exclusion diets serve to be the best mainstay, like that is restriction of the fermentable carbohydrates, which is called FODMAP diet, and we'll come to it, explain what is it called. Restriction of natural and added food chemicals. Sometimes it becomes very difficult to, restrict food. See, food today, if you buy from, of course, we restrict food from buying from the market also, junk food also, it is to be restricted. But then avoiding chemicals become very, very difficult. Then restriction of gluten is also there, because any irritant, any kind of irritant in the gut has to be removed initially. And then there is an inclusion criteria. So how do we include slowly? But that is another process. Next. So this is a very important thing, modification of fiber intake, which fiber, insoluble fiber, soluble fiber, because insoluble fiber can also have impact on the gut motility and gut integrity. So fiber supplementation, this has been done in the Western world in seed and physium, all this thing they have tried and they've seen benefits of it. Then manipulation of the fiber types, with something Bijoya is going to talk about later, how fiber is to be manipulated. Then modification of the meals and portion sizes. That's also very important. Like we can't have a lot of meal together. And then again, it is one of the things which we talk about in the healthy modifications of the diet. When we talk of healthy diet, we say, okay, have small portions at frequent intervals rather than having too big portions and all. So that also works in this. Then lifestyle change, of course, we tell everyone to exercise. So that it also holds good here. And exercise actually is a very important aspect of, we just can't leave out exercise in this, it's a very important aspect of diet nutritional management. Supplements, probiotics, we have little evidence, because probiotics is something we are exploring. There are so many strains of probiotics, which one works with which individuals, whether it works or not, and whether it is just for wellness, whether it really cures something, whether it is really effective. This is something we are exploring. So, there are very few studies for that. But yes, probiotics is definitely being explored even in India. Herbal supplements, this has been done abroad. It's not actually been tried in India. So next. So there are dietary strategies for IBS, and first thing is that we should know what are the dietary triggers, and there is no evidence. There have been studies. There are some studies going on. I can say AIMS studies are going on IBS and IBD. And we know the dietary triggers usually are dietary products, meat products. There are triggers, caffeine, cabbage, onion. There are some vegetables, beans. They could be triggers, spicy food, fatty foods, and smoked food. So what is left for us? So very difficult to plan diets for these patients, especially when you are going on exclusion diets. Very difficult, because everything you have to exclude, eliminate first. Next. So, as I said, dietary foods need to be eliminated. So low lactose actually can work. You can sort of, work with low lactose rather than avoiding lactose completely. So low lactose meaning still a person can tolerate about 12 to 15 grams of lactose per day, which means about 1 glass or 250 ml of regular milk, or maybe in the form of curds, which has low lactose, or maybe in the form of milk and cereal. If the cereal is mixed with some amount of milk. So, because milk is something very Indian, and most of the people are vegetarians. So, very little sources of proteins we get. So, it is very difficult to avoid with so many other restrictions, very difficult to avoid it completely. So, you can still manage. A lot of people can manage with little amount of lactose. And then there are some lactose enzymes available, which can allow a more amount of lactose in the diet. But again, these lactose enzymes have vary in their efficacies, and it may help some people, it may not help some people. So we have to see, we have to actually titrate. See, it can be different for different individuals, and we have to see which patients can show the response and which patients do not show the response. Next. Then fructose and sorbitol restriction, none of these things, whether it is lactose or fructose whatever diets, it has been seen in the research, they don't work in isolation. They are if they are restricted together, only then they work in IBS, and that's why it makes it more difficult for IBS patients to follow all those kind of restrictions. So if we talk of fructose and sorbitol, they are studies which have been done, but they're not been very well designed studies, and these diets have never gained very popularity amongst the patients, but fructose malabsorption, this has been seen in the as a GI symptoms, and it has been seen if you avoid fructose, there were improvement in the symptoms. So again, we come back to FODMAP diets. If we have a little bit of restriction in the lactose and fructose and sorbitol, then they start showing response. And especially fructans is a more important food in the food item, more important component in the food item, which needs to be restricted. So as I said, in isolation, everything is very ineffective in IBS. Next. So FODMAP, what is FODMAP? It is an for fermentable oligo-di-monosaccharide and polyols. So literally, it's like for an Indian, it just includes a lot of things that we eat in our day. So low FODMAP diet is found in a wide range of foods. You can imagine fruits, vegetables, breads, cereals, grains, nuts, seeds, dairy, processed foods, beverages. You talk of anything, what we eat has a FODMAP. So we have to identify foods which are low in FODMAP. And we have a list there. At the end, we can show that list. And using that list, one has to design a diet for a patient, right? Efficacy, there are numerous studies, observational studies, comparative studies, RCTs, where low FODMAP diet improves overall functional symptoms. That is the truth. If it is implemented correctly and the patient is compliant to the diet, then symptom severity and is definitely better. I mean, they show response, and quality of life of these people, IBS people, definitely becomes better than the normal diet. Next. So I'll come to the. You want to ask mechanism of action? Should I just go on, or you want to?
Please, ma'am. Please.
Okay. So as sir also said, this is a disease where there is sensation of pain and discomfort, and it is exaggerated. So there is a disturbance, obviously a disturbance in gut motility. There is increased gut sensitivity. As a result, there is gut distension. There is difficult movement of, there's a large amount of gas which is stuck there in the abdomen, in the gut, and water retention is there, causing pain and bloating, and the bowel, as a result of which the bowel habits also change, including diarrhea, constipation, or maybe both. So these are short chain fatty acids, which actually, from any source, they behave in a similar manner. It can be short chains can be from any kind of source, which will come now, fructose or lactose or whatever, but it does behave in a similar manner. And due to their small size, they're poorly absorbed or not absorbed at all. They drag a lot of water into the intestine, and they are readily fermentable by the colonic bacteria. So they are also malabsorbed in the small intestine. They enter the large intestine and get fermented in the large intestine. They generate a lot of gas like hydrogen, carbon dioxide, and methane. Next. So what happens then? If they accumulate so much of gas, water, and everything, then there is obviously an expansion in the volume of the intestinal contents. There's a stretching of intestinal wall, which triggers a sensation of pain and discomfort. So oligosaccharides, if we talk of FODMAP diet, oligosaccharides, which is actually fructans and galacto-oligosaccharides, they are not absorbed in the small intestine because humans lack the enzymes which actually digest this, breaks these chains of sugars. Fructose and polyols like sorbitol and mannitols, polyols are sorbitol and mannitols, which are slowly absorbed in small intestine and resulting in the accumulation of lot of water and movement and into the small intestine. Lactose, we all know that we can actually digest lactose very well normally, but in the absence of lactase enzyme, then lactose is passed on to the gut in the intact form, so it is not broken down to glucose and galactose. Next.
So, thank you so much, ma'am, for helping us understand what are the different dietary modifications and the diets that we could, prescribe in IBS patients. Next question would be for Dr. Bijoya. Dr. Bijoya, please help us understand what is the role of stress, because a lot of patients with IBS also have anxiety and depression along with the gut symptoms. So, what is the role of stress management in these patients?
Well, thank you, Dr. Shweta, for putting this question to me. Well, as Anuja ma'am and Shriram sir has already mentioned in their slides, like this IBS is basically due to a multifactorial consequence. I mean, it has got a multifactorial etiological factors, and not just only one thing is regulating the IBS. Now, let me give you, to start up with this discussion, let me give you one simple example. Even in our childhood days or even in our student days, also, we have seen like just before the examination, there is some kind of cramping in the abdomen and all. Why? Because we are anxious. The moment we are anxious, it is directly regulating our brain, and brain is directly regulating our GI system. So it is basically due to the gut brain axis. So this gut brain axis, what happens whenever there is a stress, there is a release of the hormone called cortisol. There is a hypercortisolism. This hypercortisolism itself is a thing which is basically triggering the symptoms. Now this, when this cortisol is being released, it increases the gut permeability by increasing the effect of the bacteria that we have inside our lumen, and also it affects the GI motility. So
Yeah.
talking about the stress before, especially the people who are working in the corporates, or now everybody is stressed out, even the students, they're also stressed out. So this stress has got direct impact on the severity of the symptoms, and also this stress management is an integrated and very important part of the treatment plan of the IBS. There are the stress actually gives rise to several of the triggers. Like because of the stress, there is an increase in the abdominal discomfort, the pain is there, the changes in the bowel habits are there. The people who are into some corporates dealing with the sales business or in the banking industry, my patients, as I deal majorly with the IBS and the gastro patients, I've seen that people who are from the banking industry, even the people who are in the medical fraternity, they are, even the teachers, they are also coming. Now every individual is coming up with the symptoms which is showing us IBS is a group of symptoms. It itself cannot be called as a disease. Okay, it is a manifestation of the various of the factors. So now talking about the gut brain axis, when there is a stress, there is a release of cortisol, which is influencing this axis, resulting in the alteration of the gut motility, sensitivity, and secretion. There is an increased visceral sensitivity also. So to manage the stress, we need to reduce the cortisol levels, and that can be done by improving the to work on the coping mechanisms, like your relaxation techniques, the cognitive behavioral therapy. Like I have I'd like to mention one of my patient who was extensively suffering from irritable bowel syndrome. Like none of the things were actually helping her. She was IBSD. Then I sent her for the gut directed hypnotherapy, so that actually helped. So this kind of cognitive behavioral therapy, also the psychiatric counseling also, could help to bring down the anxiety level. So here the meditation, and as Anuja ma'am has rightly pointed out, the regular exercise, these things are very important. The best form of workout that I have seen for the patients is yoga, because yoga is something that is a stretching exercises which is not just improving the blood circulation, it is equally helping your involuntary muscles to perform, because our GI system is an involuntary muscle. So it is also helping our involuntary muscles to work efficiently, calming us down, relieving the stress, and thus the stress induced IBS can be effectively managed.
Wow. Yes. So, as you rightly said, mindfulness, meditation, CBT, and gut hypnotherapy is something that I am actually learning for the first time. So, these are the modalities that we can use in our IBS patients. So, we can refer them to a psychologist. Acha, tell me one more thing. Is there any specific way, we should tell our patients to prepare food, especially these IBS patients? There are so many restrictions, right? So FODMAP diet में तो you are approximately excluding
Restricting everything.
everything. So
Yeah.
many a times the patients they get confused कि भाई अब क्या खाएं मतलब what should we eat. So and it becomes very difficult because whatever is being prepared in the family. So is there any specific way it should be prepared?
See, the thing is, FODMAP itself, as the name suggests, like fructose, oligosaccharides, disaccharides, the monosaccharides, polyols, and ma'am has already said, like these are present in all food. So, better way is to first of all the choice of the alternative foods which is containing say let us take the example of the pulses and legumes. Indian diet is predominantly having pulses and legumes. You go to any region, you come to east, west, north, south, everybody they consume a lot of pulses and they're so rich in oligosaccharides. So the
Hmm.
IBS patient, they cannot even figure out that what exactly is causing the problem, but that
Hmm.
is actually the presence of the oligosaccharides that are present in the pulses that are causing the problem. So one way for the pulses, I would say the soaking and rinsing the beans before the cooking and rinsing them thoroughly till the time that jhaak wala thing, that frothy thing is being washed off completely. I know a lot of B vitamins are also going to get washed away, but it is more like to treat the IBS. Otherwise, even if the vitamins would be there, but because of the irritable bowel syndrome, there is so much inflammation in the intestine that the absorption will get affected. Right. So that way, soaking the beans, lentils before cooking, washing them off thoroughly can help. For the lentils, let me tell you, while we are boiling, then after boiling it for some time, there is the frothy things that comes on the surface. That is due to the oligosaccharides. So that needs to be thrown away. So for the lentil cooking, instead of going for the pressure cooking, if we can boil it in a separate container, because in the pressure cooking, we are not having that provision to throw off that frothy thing. But
Right.
while we are boiling it in a pan, we can throw off that froth, which is actually containing the oligosaccharides. Now, talking about the garlics and onions, yes, they are the big time triggers for the IBS patients. So, to get the flavor of the garlic, yes, garlic induced or the garlic infused oils can be used.
Okay.
To some extent, onion powders are available. Those onion powders are containing low oligosaccharides because onion contains scorodose, which is the oligosaccharide. So the onion powders contain low scorodose, so that can be used. Rather, spring onions or the scallions are the better alternatives because they're also going to give you that onion like flavor. But yes, the complexities of the IBS can be well managed, and boiling, baking, grilling are better options rather than frying while talking about the cooking methods of the FODMAP foods. So these are the things can be done. Talking about the lactose, that is, we know that lactose intolerance is a very important thing which is there in IBS patient. Now, the Indian meal, they are predominant in the milk based. We eat a lot of dairy foods. For the vegetarians, half of the Indians are vegetarians, not half, rather 70% of the population I would roughly quote as vegetarians. They can have paneer because paneer, first of all, it is fermented. Secondly, the paneer undergoes a lot of pressure. It is being produced, and lactose being water soluble in nature, with that kind of pressure, that water gets removed also. So even if there is a lactose, the content of lactose in the paneer is quite low. So
Okay.
instead of a glass of milk, they can have up 50 grams of paneer, which probably will give them little less trouble. And one more thing that I've seen, if they cannot go for those enzymes, because there are a lot of lactase enzymes available, as ma'am has rightly pointed out, they can also go for asafoetida, the hing that we say. Hing is a very good IBS problem reliever. So even if they are having, say, the bloating wala food, the foods that are actually containing the FODMAP foods, so
Mhm.
ask them to have a little quantity of it instead of completely omitting from it, because FODMAP diet is more of the restriction. They're restricting it for 2 to 6 weeks, then reintroducing it one by one as a trial from the 8th week onwards to see that which one is better suited. So it's, and now there's another concept called the nice diet. The nice diet guidelines, they are saying that do not restrict all the foods, because that way the patient become more agitated, the patient become more anxious, and that anxiety also, like kya khaye, what to eat. So that way patient, what can be given, like they need to identify the triggers, because all FODMAP food do not cause IBS like symptoms in all patients. It is all
Mhm.
about bio individuality. I may react to paneer, the other person can react to curd also. I've seen the people, the curd is not having lactose that way, that is having lactic acid. But
Hmm.
still, people with IBS, I have seen, I couldn't give them curd because the moment they're having curd, they're coming up with the IBS like symptoms. So we need to figure it out patient by patient, which is very it is easier for us in the private practice because there we are in a position to judge the patient individually. It is more about the judgment, it is more about educating the people
Hmm.
that which food is actually causing you trigger, then probably you omit it for certain time. And also, like, there are certain vegetables like cauliflower, broccoli, Brussels sprouts, which are anyways very high in FODMAP. Like, even if you're throwing away the water, still
Okay.
they are high in FODMAP. So limiting their intake is one option. Second option is khana hi hai, have it weekly once, maybe in the weekend night, so that the next day morning, even if they're bloated, they're not bloated the entire day, their discomfort is not there the entire day,
Hmm.
it would be there at night and then it would get washed off the next day morning. So that is another option. Then choosing the low FODMAP sweeteners like glucose, sucralose, or stevia instead of the high sweeteners, high FODMAP sweeteners like honey, high fructose corn syrup. Many people into because they want to reduce weight, because obesity or the overweight has got a direct relationship with the irritable bowel syndrome because of the presence of inflammation in both the
Hmm.
cases. So
Hmm.
choosing them is better because the obese people, they have a tendency to take lemon honey in the morning, but
Okay.
that way that also triggers the IBS.
Hmm.
And reading the food labels, that is very important to identify that what all are the FODMAPs, because to limit a particular food group for a certain period of time is okay, but if you're having the processed food that most of us are doing, like we are going out, we're having food, we're having certain packaged foods or processed foods, therein it is very difficult to identify that if at all they've used any FODMAP foods or not. So it is better to go through the ingredients, and as ma'am has said that there are list of charts that are available to see that if something is there or not, and then to avoid it. That is going to give them some kind of relief, you can say.
So also, Dr. Bijoya, are there any Indian traditional food and basically that like जैसे हम घी की बात कर रहे हैं या फिर if you're talking about spicy, Indian food is anyways very spicy, right? So are they to be restricted or like what is their effect?
See, the spices are not the problem. The problem is with how we are cooking the food with lot of ghee, with lot of oil, frying, then lot of onion, lot of garlic. That is
Okay.
the problem. But if I am using, say, boiled something, or say maybe a light sauteed item with the
Hmm.
with the spices, spices are not going to create any problem because you talk about the bioperine.
Hmm.
Bioperine, which is present in bioperine, is a synthetic form of the piperin, which is present in the black pepper. Black
Okay.
pepper mixed with turmeric increases the efficacy of the curcumin which is present in the turmeric. And turmeric itself, like we Indians, we are blessed because we already have it in our traditional form. We Indians use turmeric in almost all food preparation. Turmeric contains curcumin, which is such a good anti-inflammatory and antiseptic thing, and that itself is very good for healing. So turmeric has got anti-inflammatory properties. We Indians, we use adrak ka paste, we use ginger.
Hmm.
Ginger itself is anti-inflammatory. Talking about the fibers, it is better to switch on to the soluble fibers, because even if there is an IBS-C
Hmm.
patient, but it has been seen that for the constipation, we know that how important it is for
Hmm.
an IBS-C patient to have the lot of fibers. But these insoluble fibers also give rise to the bloating, the mechanism which Anuja ma'am has already explained. So it is better for IBS patient to go for soluble fiber like oats. Oats is containing beta glucan fiber, which is a soluble fiber. Then we have rice. Then we have, instead of wheat, why to go for wheat? We have the
Hmm.
millets also. Like if at all you cannot eat rice, one patient can go for millets.
Okay.
2023 is anyway the year of millets. We all have been promoting it. The government has been promoting it. The millets are the gluten-free option because the gluten. Somebody asked the question also that how gluten affects IBS.
Hmm.
Basically, there is a protein called zonulin. This zonulin gets activated because of the gluten. So whenever a patient is consuming gluten, and if that particular patient is affected with gluten intolerance, or even if they're not affected with gluten intolerance, that gluten, it activates the zonulin protein. This protein is basically responsible for the membrane permeability in the gut. And this bacteria, more the elevated levels of zonulin, the better the adhesion of the harmful bacteria to the walls of the colon. So
Hmm.
that is the reason the even the IBS patients, even if they are not gluten intolerant, has been asked to reduce the gluten so as to improve the better things. So talking about the fiber, rice is a better option as compared to the wheat. And dairy, I already told you that if at all they cannot even tolerate paneer also, then the expensive version of the almond or the soy milk is available. And if somebody is vegetarian, then they can probably increase the fish and all fish and eggs, because the chicken also has been found to be
Hmm.
increasing the IBS-C problem if somebody is coming up with the IBS-M type. So for
Okay.
them also it has been found that their constipation thing gets increased, or too much of protein, because protein chicken takes a good time to digest. So too much of protein also
Hmm.
let the bacteria grow into the intestine, because the bacteria, they get a good time amount of time to break down those protein. As a result, a fermentation is caused, and the stool becomes sticky, it becomes smelly, which also triggers the growth of the other unwanted bacteria. And talking about the ghee is tolerated better than the regular butter, because butter still contains casein, but ghee is not containing casein. Casein sometimes, yes, do trigger. So if somebody is having intolerance towards the paneer also, then they can go for ghee to some extent. Yes, they can have.
Uh, just let like share your thoughts on what would be the right beverages for these kind of patients. Like would green tea, like a lot of us drink green tea or kava or something like that, or would they be contributing or would they be beneficial for IBS?
Green tea is definitely beneficial for IBS because of its ECGC content. The catechins are there, which are itself anti-inflammatory. Talking about the caffeine, as ma'am has already said, that caffeine is a trigger. So caffeine drinkers should be avoiding it. But the
Mhm.
IBS-D patient who suffer very frequently from the diarrhea-like symptoms, for them,
Mhm.
if they can have that peppermint tea, it is
Okay.
very good for them. It soothes those symptom. I mean, that continuous peristaltic movement of the intestine can be well controlled by the use of the peppermint tea. Even there are various herbal infusions also, which are very soothing to the digestive systems. Yes, that can be done. But most importantly, it is about eating
Mhm.
it is about the portion size. So portion size is not just important for a diabetic or obesity patient, but portion size is equally important for the IBS patient, because larger meal contributes to bloating, gives rise to the fullness, and they feel like to go to the washroom again and again, and the instant bloating is there. So it is always advisable by the IBS patient to have smaller frequent meals rather than the larger meals, which is going to give them a very calm sensation to the gut.
Right. Thank you so much, Dr. Bijoya, for shedding light on how to prepare food and what are the things that we can do ourselves and we can also help our patients do at home to, manage their IBS. Coming to next question, I would like to ask Anuja ma'am, what is the role of probiotics in these patients?
Yeah, as I already said, Shweta, that probiotics may be beneficial, but then there are individual differences. As for all the foods, what we say is in IBS, foods like rice and potato could be helpful. While on the other side, we say that you go slow on this, because for the lifestyle disorders, we say that have more fiber, have more soluble fiber and things. So. Probiotics have different bacteria. We know that it has different microbial concentrations, and efficacy could be different. Our traditional fermented foods, as rightly said by Bijoya, paneer, curd. Curd also has low lactose. Even paneer has low lactose. Yogurts and pickles are a good sources of probiotics. So it may support a gut health, but it may differ from patient to patient. Tolerance also need to be tested over time. So you may have to work very hard on these patients for compliance and
Mhm.
monitoring, okay, and titrating their diets each time. So it is a very hard job for the dietitians as well as for the patients to work hard, to follow the diets. Not all probiotic strains could be helpful, and which one is very difficult to identify, because the strains, there are so many strains, difficult to try The trials are also very difficult. How which ones to pick up and which ones to try on the subjects. So it's a matter of this is something to explore. However, as Bolari is supposed to be found to have beneficial effects, and but still it is a low evidence because the sample size is low at the moment. So they have to do trials on a big sample size in India. An Indian population could be different for probiotics, the response to the probiotics, and to a typical probiotic like S. boulardii. So one has to see IBS patients in India would respond to that. And definitely studies in Indian population is lacking.
Right. And I mean, these would be the medicated probiotics, not the usual one that we have at home. So, I mean, nothing like.
Yeah, these probiotics, what I'm talking about, the commercial ones, but yes, Indian probiotics, the natural probiotics, one could try. As we say that the low lactose, we in any case allowed some amount of curd, we in any case allowed paneer, yogurt, and we are anyway we are allowing these things, and pickles we are having, normally having at home. So these are natural probiotics which one can easily have, and whatever in permissible amount or in restricted amount, we can advise them. But going for the commercial probiotics, which one will be responsive to which patient, this one has to see. This can vary from patient to patient.
A lot of us think that Yakult is the only probiotic. So, so many times we need to sensitize people and patients and our fellow nutritionists that probably that there are so many commercial preparations, and I think, as you said, we'll have to try. And can it be different for different people?
It can be different for different people, but it is still as I said, the subject to explore. I think Sir can also comment on this. A lot of medical colleges are doing trials now on probiotics. It's one of the things which is treated good for wellness, but it is not measured. How do you measure wellness? So
Right,
and
right.
similarly for IBS, from patient to patient, strains to strain, it can vary. Sir can also comment on this if he has some experience in this.
Sir?
Biotics, as per the data and research guidelines, there is no basis.
Yeah.
The trials are difficult to conduct, and strains, what quantity and what quality.
Yeah.
We use, not in all IBS patients, they're predominantly used in patients who have diarrhea predominant IBS, not in constipation predominant IBS. And there are no guidelines. As per guidelines, they are not recommended to be used in IBS.
Yeah.
But yes, as research protocol or as per your experience, you can use them. And there is nothing to choose because there is no data and there is no basis for that.
Right, right, right. Dr. Bijoya, would you like to add something?
One thing I'd like to add up here, the probiotics, we all know the definition of it, but we need to give them the food so that they can multiply. Because even if I'm giving the probiotics at certain CFU, they have got a particular lifetime. And the bacteria, they need certain medium for their growth. And those medium or those nutrients are the prebiotics. So probiotics along with the prebiotic supplementation is the actual thing. Because, the probiotics, when they feed on the prebiotic fiber, prebiotics are readily available. You talk about the oats, almonds, banana, all these are containing the prebiotic fibers. Even the pista nuts and also prebiotic fibers are widely available. So combining the probiotic and the prebiotic, some mixture, maybe if keeping it for some time and then have it, so that way the postbiotics like short chain fatty acids are being released. And these short chain fatty acids, what happens, like they help to they are the basic thing that are colonocytes they require as a source of energy. And once these colonocytes, they take up these postbiotics as their source of energy, they try to become more strong, and thus they prevent the leaky gut. So that way the harmful bacteria, they cannot enter the lumen of the intestine, and thus the inflammation can be reduced. So that way also the IBS symptoms, not in overnight, but yes, after a regular consumption, that I've also seen in my practice, like I've given the combination of smoothie, normal smoothie that I've given, I've replaced their breakfast with the normal curd, oats, banana, almond smoothie. I said that you prepare it, keep it for some time, and then you have it. So
Right.
that way, because these probiotic bacteria are all acidophiles, we have to understand that they're all acid-loving bacteria. So these bacteria need to grow, need to multiply, need to release those postbiotics, and then they can travel very easily through the gut actually your tummy says that yes, I'm very happy. Like I have seen the changes in the patients after consuming that, and gradually their symptoms, they also improved over the period of time. Nothing happened overnight, because nothing can happen overnight. IBS is a chronic problem. But yes, with the due course of time, the tolerance towards the other FODMAP foods, I have also seen that have increased over a period of time. So
Right.
the postbiotics, more researchers are definitely needed, that what all are the other different postbiotics, because it is not just the short chain fatty acids, the butyric acid only, which is being produced by the this as bullardi, but there are other postbiotics also. Maybe in future some more supplement form are to be needed to implement it into the diet of the patients for the better efficacy.
So
Okay.
I would just add here, as a research medical institute, we really don't recommend this, unless we have a sure documentation,
Evidence.
just evidence, we definitely, I would just go against it, and I do not recommend.
Right. Maybe it needs more evidence as of now.
Yeah, yeah.
Right, right. So next question, Dr. Bijoya, goes to you. I see a lot of patients with sleep disorders, and I've seen like people who are unable to sleep. Many times they develop gastric irritability, and the symptoms are similar to irritable bowel syndrome. So, what is the role of circadian rhythm and IBS, and like what is the correlation? Dr. Bijoya,
Yes,
over to you.
very well put, because chrononutrition, as we term it as, is the basic current research that has been going on for almost, and they're trying to figure it out for almost all the diseases, and not just the IBS, but IBS is directly or more or less very largely associated with the chrononutrition, like at what is the time of the food that we are eating. If we go to our basics into our ancient system, according to Ayurveda, they have said that there are three doshas, Vat, Pitta, Kapha. Ayush, they do the treatment according to that. So according to that, there are three time slots in a day. Morning 6 till 8 is the time for Pitta, and then afternoon 12 to 2 it's the time for Pitta, and then again evening 5 to 8 it's the time for Pitta. And you will see that during these times, I believe whoever is the audience over here, we might have experienced that these are the times when we feel the sharp hunger,
Hmm.
and that is the time when the food is better tolerated. But because of our work schedule and all, what we all are doing, we are coming home late, we are
Hmm.
sitting for the dinner late, we are eating the food late, and immediately after eating the food we are going to bed. And
Hmm.
now if we are going to bed, our brain, it is at rest, then who
Hmm.
is going to really help in the release of the hormones?
Hmm.
So the circadian rhythm that is being largely affected
Hmm.
does play a very major role in our body, because circadian rhythms can be physical, mental, behavioral changes that we follow over a 24-hour cycle.
Hmm.
Like when we wake up, when we go to sleep, that way our biological clock has been set, and this is how our genetic makeup has been over the period of ages, over the evolution, right? This is what it has been. We are not like the other animals who are waking up at the night. So now when we are going against it,
Hmm.
obviously some form of issues are coming out, some things are coming out. We have seen that the people who are working at the night shifts, or
Hmm.
the IBS D type patient, if they are sleeping little late, okay,
Hmm.
then the next day they complain of having diarrhea,
Hmm.
because the biological clock in the is a natural timing device which regulates everything. The release of the hormones,
Hmm.
they depend largely on the, being a doctor, when you know that they depend on the diurnal variation. With the daytime the hormone levels are certain, and at the night time the hormone levels are certain, and that is the reason even several cardiac medicines are also prescribed depending on the timing. The timing is very important, which is actually regulating the aldosterone hormone and all. So here in this case of IBS also, the light dark cycle that we have impacts largely on the integrity of the intestinal barrier.
Hmm.
Because of this light dark circle, the people who has been not sleeping well, it is not just that they're sleeping late or they're the night shift workers, those who are not getting the proper sleep also are actually increasing the inflammation, leading to the leaky gut, resulting in the gut dysbiosis. So that is also another thing. Another thing is that this waking up at night
Hmm.
for the work, what happens when especially the night shift workers that you have mentioned, these night shift workers, they over the period of night hours also, they're at their anxiety, the anxiety level is high. So this anxiety, their anxiety level gets doubled up, because in the daytime also, because of the noise and all, they're not getting the appropriate sleep. At the night they cannot sleep due to the work, due to which the anxiety level crops up, it doubles. And I have already explained previously in our discussion today that how anxiety plays an important role in the onset of the IBS. So human circadian rhythm disruption is definitely detrimental to the GI health, to the GI motility, and thus can be a possible contributory factor for the IBS.
Right, right. And actually, what happens during the insomnia, there is an imbalance of cortisol on melatonin. So, usually the cortisol would increase. And just like you talked about the role of cortisol in causing gut inflammation, there is a possibility that the cortisol and melatonin imbalance probably would be leading to the inflammation in these patients, which would also lead to the gut inflammation in
Yes.
association with the rest of the inflammation.
In fact,
Absolutely.
chrononutrition is gaining a lot of importance now because people having a lot of night sleeps and eating in the middle of the night. So these are all actually bad habits which are, due to fast pace of life or whatever lifestyles we are leading. So I think chrononutrition takes back to our ancient times where, they say that eat your food at 7 o'clock and don't eat anything after that. Have a nice good sleep and all that, But I think
Yes.
it's something which becomes very impractical in today's world. So it is getting a lot of importance. Yeah.
Also, another thing is, ma'am, like the small intestine or the colonic activity that we really talk about are higher during the day than the night. So now,
Oh,
when we are having very late food, the food has to travel through the colon. But that time, the colonic activity is reduced. So there is a reduced gut motility also,
in
resulting
fact,
in the
yeah.
development of the small intestinal bacterial overgrowth, which is also resembling the symptoms of irritable bowel syndrome. That is also another.
Similarly, I mean, as a pediatric nutritionist, I have seen the increase in the constipation in children a lot. Because the bowel habits are so bad, they don't go to the toilets in the morning because they're having a very late night sleep and then they're watching TV or they're studying. Maybe they're only studying, but they're having very late nights. They're not even having a proper sleep. They're not eating on time. So the chronic constipation, functional constipations, they're really on a rise even in children. So
True.
yeah, so our whole lifestyles need to be changed. It has to be a balanced lifestyle. Yeah.
I mean, apart from pediatrics, I think after the COVID, everybody's schedule because of working at home, because the schools were online, so screen time has increased, sleep rhythm has become more chaotic,
Yeah.
and I mean, these problems are cropping up more and more.
Yeah.
Ma'am, Anuja ma'am, I would like you to actually tell us in brief what would be the right way to, create the personalized plan in these patients. So, I mean, please shed some light on it.
Yeah. So as I said, FODMAP diet itself is a very tough thing to design. And as Bijoya rightly said, that just avoiding everything, complete avoiding of everything is not possible, and we don't do it nowadays. It is restriction of minimizing the things which are and triggers. There are a few triggers. If you just avoid these few triggers for 3 to 6 weeks, that is the time where strict restrictions are implemented. After that, there is a gradual inclusion of food one by one. So it is elimination, exclusion, and then inclusion, and then seeing the effect of each of these foods. So low FODMAP diet is the optimum line of treatment. First, management of these patients, then exclusion of triggers is very important, which we have said in the initial slide. However, inclusion challenges may be done as the tolerance of it is very individual based. So the challenges by including a particular food is done, so that is called a challenge. We are giving a challenge to a person. Then compliance is monitored, and regular monitoring is very important. Then restriction of food rich in FODMAP as a difficult diet. We can show you one of the things, how what are the kind of foods which have oligosaccharides, which have polyols and all that. So there's a list of things which one can follow. Okay, these things are omitted, the rest of the things we can give in the diet, and accordingly the diet is planned. Then one needs to know very crucial things. The science of food is very, very important. As Bijoya has shed light on some of these enzymes and the science behind the food. Similarly, the soya milk, which is made from soya protein, is low FODMAP, but which is made out of soya bean is high FODMAP. So imagine, if you don't know this, then you will completely avoid soya milk for the patients. But how do we know whether this soya milk is made out of soya protein and this milk is made out of soya bean? Right. So maybe this soya milk protein concentrates are available, in which you can just use them rather than using the soya bean based milk and all. So one thing about soya bean is not clearly written. What is in the commercial soya bean products is not clearly written where it comes from. So it is to me also, it's a mystery about soya bean, is a real mystery, and we need to understand it better. Then likewise, there are so many other things which we need to actually look back into the science of the food, and then we can implement it, right? Then, of course, I was just talking, this is IBD NutriCare app in AIMS, not IBS, but it can really help, people. One can just look at this app, which is being designed by AIMS group. Next. So there are 3 steps one can follow in this. A low FODMAP diet is implemented for 2 to 5 weeks, and then if it is adequate response, then one can go on to step 2. If there is no response, inadequate response, then I can't see this. Can you just make it a little bigger? Yeah. So one can see inadequate response, one can check the compliance and consider what are the troubleshooting strategies. Maybe the person is not compliant to the diet. That's why there is inadequate response. So one can give it a try again and see. But still, if there is inadequate response, one just forego the FODMAP diet and try other therapies, alternative therapies. But if it is adequate response, then one can go for the challenge each FODMAP subgroup separately. So as I said, we challenge in step 2, and then assess the response of the challenge, right? If the challenge, they show they can tolerate some kind of food, that can be included in the diet. And it is different for different individuals, as we have already saying right from the beginning. Then some individuals can tolerate certain things, others can tolerate the other things. So it's not just one size which will fit all. Then go into the third step, where establish a personalized format. Once you have identified that this person is tolerating these kind of foods, and one can play around with those kind of foods and plan a personalized diet plan for that person. So likewise, the diet plan will be different for different people. So I think for dietitians, it's a very tough task, to do.
Right, ma'am. So personalization probably is the key, and every patient would be different patient actually, and restriction might be different for different people. So
I would just like to say also, a lot of people these days, just want to say कि okay, इस disease का एक app बना लेते हैं, so that it's very easy for doctors and all. You are a doctor, but I'm telling you that बहुत आसान हो जाएगा, हम चार्ट निकालेंगे और दे देंगे. Frankly telling you, none of these conditions, अगर diet से therapy करना है, and most of the conditions, we are going back to nutrition, and we are seeing that more and more of these problems, whatever problems, are managed by nutrition. Like we do epilepsy with ketogenic diet, we manage this and 100% response, right? So we know that. But if you make an app for everything and think that the patient will, you can just take out a chart and give it to the patient and there will be compliance. No, it is never going to happen. It's never going to replace.
And it's a very personal, cultural thing. Yeah. I mean, in every family has a different culture. And
it's never going to happen. It's never going to replace the human beings.
Definitely. I totally agree with you, because the choices हम कर रहे हैं as a family, and we live in a family, and it is very difficult to make an individual food at a time. So if you like there are 5 people in the family, so you would create a food which is like according to everybody's taste or something, because it is very difficult to create 5 different, food, to serve 5 different types of food at the dinner table for different people. So
Right.
I think it's more of a cultural thing. It's more of a personal thing, and there might be some restriction in somebody's family, and some taste preferences are there, and ginger, whether to have ginger or not ginger, whether green tea is good or not. There's an emotional aspect, psychological aspect to it. But then, as far as IBS, what as you have told me that, or as to you have told all of us that probably the it's the exclusion diet that works, and the takeaway message is we cannot exclude everything, but at least we can look for those foods which are low in FODMAP ingredients, and we can avoid the foods which are high in FODMAP. And even if we cannot avoid them totally, we can at least restrict the amount per standard serve. So there are few recommendations, right, for every subgroup, that how many grams should be there per serve, so per individual food. So let's say for oligosaccharides, or which is like in the form of grains, or for vegetables, different values are given, right? And I think
Their cutoffs, the values are given.
Cutoff
They're given
values.
by Monash, but some of the research, if you agree, Bijoya, we need
Yes,
to do as a nutrition scientists. We have to do some research and see whether our foods are also fall in the same category.
absolutely.
But this is
Absolutely.
chart has been given by Monash. A fantastic job has been done, and they have an app where people can join and see every day they are posting various recipes and all that. So
Right.
really, really insightful. Yeah.
And
Actually, because of that, at least we are having certain guideline that what all are there and what all are not there. Many IBS people, they love to eat bagan, brinjal, even eggplant. That is also high FODMAP. For the
Yeah.
bananas, the overripe one is a high FODMAP, but the little less ripe one is the low FODMAP. As ma'am was giving the example of soybean, so it is this app that ma'am has been talking about is actually very a
Very
good
helpful.
guideline. Yeah.
right. So I think this is the list that has been given with Monash, and wherein the high FODMAP subgroups are highlighted, and the typical items in that particular subgroup which are usually eaten are highlighted. So these, I think, is the list ma'am Anuja ma'am is talking about, and this is what we should look at while we are planning a diet for the IBS patients. And I think we have already covered what is the pathophysiology, what are the symptoms, what are how the food should be prepared, how it is an individual's choice, which should be taken care of while planning a dietary management plan for IBS patients. What is the relationship of sleep and IBS? And how managing sleep can also help you manage your gut irritability in your patient. So I think that has been a very comprehensive talk, and all the speakers have very nicely covered our doubts, and told us in a very comprehensive manner what IBS is all about. There are a few questions, I think, from the audience, and somebody wanted to ask that what is the rule of gluten-free diet in IBS patients?
That I
Anushka?
already said. Okay.
Yeah. She
Right,
already explained in detail,
right.
about gluten-free diet, what are the enzymes and how it triggers even in IBS, not only in celiac disease,
I
right?
think was another question by Dr. Kanta Sharma, and we have already given the list, right? And somebody asked about Yakut and any other lifestyle measures. Lifestyle measures, I think we have already covered that: having small meals, having the right amount of sleep, sleeping at the right time, maintaining the circadian rhythm, and including more of the fiber, and taking care of which fiber to be given at what point of time. And
Shweta, there is one, now that a lot of people are going towards traditional things, and Ayurveda is also getting a lot of importance. So when we talk of small portions at regular intervals, while Ayurveda talks about having one meal, major meal, and whenever you feel hungry, then only you eat, and your last meal should be eaten at 7 or 8, not
right,
beyond that. So don't eat unless you're feeling hungry. So I don't know, I mean, somewhere we have to, people are confused, that modern dietitians are saying this and the Ayurveda, something else is written. So I think somewhere we need to all sit together and decide what we want to tell people. And any sir, Dr. Shriram has any take on this?
I can give you the practical take. I see day in, day out these patients.
Yeah.
The first and foremost is the problem is the patient's acceptance of the problem. They just want solution. They don't want any changes.
Ji.
The first hurdle in managing is their acceptance that this problem is not an organic disease. It is the temperament of their stomach and their own temperament and brain's interpretation of the signals. So the major drawback is there. So to win their confidence, to make them understand. And secondly, the other coin of the nutritional management which we see is that I see patients who say that I have stopped this, I have stopped this, I have stopped this. I just eat these two things and still I am uncomfortable. So there is other aspects. So patients take it in other mode. So they label their symptoms to almost everything, which is again a wrong thing to do. So that is what we explain them. We improve their visceral sensitivity by giving them certain pharmacological agents, and then ask them, now you can start these things which you have avoided, and then they start eating and tolerating them well. So there's the other coin. So there are dietary trigger factors which patients are made to understand that just with one incidence, don't label them those foods as dietary triggers until there is a consistent association. So diet does have a role, but is not the only contributory factor or is not the only solution to their problem.
Right, right. There is Dr. Kant.
Dr. Sharma has also asked, that doesn't homeostasis help in increasing digestive activity during night instead of day with changing lifestyle?
Ji.
Bijoya, because I have very little, knowledge about chrononutrition, so I'm just learning it. So Bijoya can answer this.
Yes, ma'am. Basically the problem with the irritable bowel syndrome patients, as I have said, like there are various factors, not just one factors. And most important factor is that they are going through a phase of leaky gut. There is already an inflammation. The inflammation is very high. So when there is an inflammation is there, when the dysbiosis is there, anyways, their body is not in a static condition. The homeostasis itself is being regulated by the cortisols. Right. So even if for a normal person, yes, with the no symptoms of the IBS, with the no problems of the IBT, and when everything is in order, probably homeostasis could have been a solution. But when there is an IBS, and most importantly, IBS is present with the people who are working in corporates, people, especially almost everybody is nowadays suffering, the children, the students, even the PCO patients, they are also exhibiting the problem of dysbiosis. The hypothyroid patients, for whom the gastric acid secretion is low due to the consumption of the levothyroxine, their gut motility is slow. So the colonic transit is very less. The harmful bacteria, they are growing at a much faster pace because they're getting that space in the ileum to multiply, and then they are also exhibiting the symptoms just like that of the IBS. My research paper on this same has already been published also. So this is also one of the cause. So with so many metabolic problems, and most importantly the dysbiosis, this dysbiosis itself is a condition wherein there is a disbalance among the good microbes and the bad microbes. The whatever metabolism we are showing is not ours. Whatever disease we are manifesting is not due to our own metabolism, but due to the metabolism of the metabolites that are released by those microbes in the body. So anyways, my homeostasis could have helped me if my body could have responded to my own metabolites, but it is my body which is behaving how the metabolites of those bacteria are gifting me. So that way, even the homeostasis is not actually, that is the reason that homeostasis is not being able to control the symptoms. Had it been there, then the IBS wouldn't have triggered. We would have been in a much blessed position.
Right, true. I think that has answered your question, Dr. Sharma. I have also shared the list of the food items and the recommendations per gram.
Thanks very much. Thanks.
Thank you, ma'am.
Right. Ma'am, there is another question from Miss Rachna, and this is especially for Anuja ma'am. And she wants to ask that as per Ayurveda, one statement is not fixed for all Prakriti. Like for Pitta, we never call for one meal. So there is actually confusion with Ayurvedic nutrition. And maybe I think she just wants to point out that Ayurvedic nutrition is talking the same thing that as we are.
Okay. Okay. So, since we are not experts, a lot of people have now going through details of Ayurveda, but frankly telling you, because we have not gone into the details of Ayurveda, I can't consider myself an expert in Ayurveda. So that's why sometimes I feel, because now Ayurvedic Institute or millets people, they call me for an talk, then I feel there is a confusion between the two. For that confusion, we should all sit together and we should find out. I've told them also, we should find out the mid solution, which we should be talking, all should be talking in one language. I mean, people can't be confused when we are talking in different languages, right?
Right.
So
Right.
that is my whole state.
I think it was a very informative session, and I think it is going to contribute to everybody's practice, including mine. And we all learned a lot of things, especially as a clinician. I learned a lot of things, and I'm sure then all the attendees over here, which are doctors, nutritionists, and other healthcare professionals, also have gained much from this webinar. So a lot of things like how to cook food, what to prescribe, and what to tell patients when the patient has IBS symptoms. So, I mean, a lot of things are now clear, more clear, crystal clear to us.
One thing I would say, which Dr. Shriram also said, I think it's a multidisciplinary thing, and we should always, I always tell the dietitians also, we should always discuss with the clinicians. Only then we have a proper understanding of a patient, right? We ourselves take a history, doctors also take a history, we found out something, doctors also find out something. It has been my practice in AIMS always to discuss my patients. Because if we see that, if we say it is multidisciplinary, then we should always get into a discussion and discuss our patients. Only then we can help.
True.
Right.
Very true.
So very true, ma'am. And I think it's always when the different healthcare professionals who are taking care of their patients together, that is the only way, because patient is one person as a whole. It is not like the medicines are one thing and nutrition is one thing that, work as separately. And if there are any feedbacks for this session, I would like all of you to please share your feedback. I have given the email, and which is care@knowledge.com, and if you are unable to mail, just please go on to our website www.knowledge.com, and you can just leave a message over there. You'll get a form wherein you can submit your comments or submit any message to us. And thank you so much, Anuja ma'am. Thank you so much, Dr. Shri Agarwal sir, and thank you so much, Dr. Bijoya, for sparing time for us and sharing your knowledge with all of us. And I think there are so many attendees who wants to thank you personally also. And thank you so much. And if there are no further question, I think it has been a long talk, and it is already a dinner time, and I think we will break today for the day. We'll call it a day. Thank you so much, ma'am. Thank you all the attendees for being here. And I think sharing the knowledge only helps you, grow as a healthcare professional. And I think with everybody's comments and all the questions that we had, and that was also led to a very good discussion. Thank you so much once again. And with this, I think I'll finish this webinar.
Thank you so
Thank
much.
you so much.
Thank you so much.